are back at Journal Club. Welcome everybody. Welcome. Hopefully we'll get our number over 7,000 this week. That's the goal, to have that many viewers. So we are here in Newark for Journal Club. I know I sent the weekly email out incorrect. I know in the subject line it says that we're in Newark, and the body of the email it says we're in Monarch. Sorry about that, but it is the fourth Wednesday of the month, so the fourth Wednesday we are always in Newark if I screw up again. And we're here on D11. If anybody is at in South Jersey right now, I'm sure you can drive up here. We all just came back from San Diego, where two of our fellows presented abstracts that went very well. And like most good researchers, we are all ready to submit them to to journals immediately to get published. We will go through some of these articles. If you again want to be added to the email list, as you know, the journal articles now are on the website because we're advancing into the better technology age, and our website's coming up sooner thanks to crack search engine optimization. But we only keep the journal articles up for a brief period of time because of copyright rules. Just remember that. So they're not going to be up forever, but the journal videos will keep up. So, but if you need an article that you really want, you can always email one of us, and we can get it for you if it's a back article. But of course, we're only using these for educational purposes anyway, not for anything else. So we're going to go through our journal articles. Let's just start with interesting cases. Can I just review really quick a pet peeve of mine that I've been working a couple of RDU shifts, so inpatients, and I keep seeing people for syncope ordering head CAT scans and carotid Dopplers. What are people doing? Didn't you guys learn when you were like in second grade not to get a CAT scan of somebody's head if they pass out? If you have syncope, it's cardiac, cardiac, cardiac. And if you wake up and you have no neurologic findings, and every study published on this is the same thing. If you have neurologic findings, you need a CAT scan of your head. But of course, no kidding, right? You don't need any medical training to know that you need imaging of your head if you have a neurologic finding, right? But if you have nothing and you syncopize, you need to think of the heart, and you need to work that up. You don't, and there are all these rules like the San Francisco syncope rule, but all these other, and some are just common sense rules anyway. But you don't need a head CAT scan, because if your head CAT scan is only going to be positive if it's your bilateral hemispheric issue or reticular activating system. Otherwise, it's not going to be positive. So you're going to have mental status changes or some deficits. And carotid Dopplers are just more silly tests. If you stumble across something, it probably has nothing to do with your syncope anyway, because you still have your vertebral arteries blocked, so you brain that way too. So are we all in agreement that there's still some silly doctors out there who are still getting head CAT scans and carotid Dopplers for people who syncopize that's not necessary? Why is this? Why are we failing here and still doing these tests? Any idea?
Not sure. It's like a dogma in some areas of practice, I guess, that somebody comes in with unexplained syncope, or even if they have a good story. I work at a few community hospitals, I guess you could call them, and people who have a great story, young teenagers for vasovagal, they saw blood at work and passed out, end up getting CAT scanned and admitting for tilt table testing. Maybe I think that's a little overkill. There's no neurological finding on an exam, you're done. I don't think you need a CAT scan.
Not everybody needs a tilt table test. You guys know what a tilt table is? I mean, basically it's an EP study, right? We sit somebody up at 70 degrees on a table, and it's called neurocardiac syncope. It's when the sympathetics activate the parasympathetic, so they get bradycardic and hypotensive as opposed to tachycardic. And what happens if that test is negative after being on 7 degrees on a tilt table test, then you put them on an isoproterenol infusion. Isoproterenol is pretty much a pure beta, right? So the beta activates the parasympathetic. So when you start the isoproterenol infusion, then you subsequently, once you start the isoproterenol infusion, then you get bradycardic and hypotensive, and you have a positive tilt table. And if it's abnormal, what do we tell everybody? A, more salt in your diet. And then we also put some people on a 1A antiarrhythmic, which is beta pace, right? Which has got heavy duty anticholinergic properties. So, and some people actually go on theophylline as well. That's another agent which you can put somebody on. So,
you'll be awake just having seizures,
Right.
You're gonna get a few more CAT scans.
Right. So I don't know. I mean, there was a community hospital, which not New Jersey, which had a 13-year-old girl pass out during the summer, and they got head CT, and they got PT. And I don't know why you get a PTD on a 13-year-old girl who passes out on a hot day and not eating. It's another couple $100 wasted. So, any thoughts on this? Didn't you guys learn this like in medical school?
What are your thoughts on troponins?
What?
What are your thoughts on troponins for syncope?
Yeah, I mean, a troponin for somebody who's, I mean, the 13-year-old girl, they got a troponin on her too. Thank goodness. And if her troponin was high, I would have said the lab is wrong, and I don't care, and I'm not going to repeat it just because, right? That's how silly it is. I think that the science says if your troponin is less than 1, the majority of people, it's non-cardiac in nature. And if it's less than 2, it's about 10 to 15% is non-cardiac in nature. So these indeterminate troponins, most are non-cardiac in nature, right? And even up to 1 is non-cardiac in nature. So
I
think
there's
for
like an abnormal EKG finding, or so you see something on the monitor that's concerning for ischemia, maybe.
yeah, but I don't know. I mean, listen, if you're 80 years old and you syncopize, 1, you're probably not going home, right? If it's true syncope, because there's probably an arrhythmia. And 2, if I'm going to put you in RDU, I'm probably going to do an echo on you, right? And I may do a stress, but those people I'm probably going to do a troponin because it sounds like the right thing to do, even though the yield is very low, because I believe that people don't present with cardiac ischemia with ACS with syncope. That's an unusual way to present. Do you agree with that?
I think we had this a couple of years ago or sometime, since we have ultrasound in our vehicles, we had a young teenager who had a syncopal episode while playing sports. We did an echo, and we found that he had cardiomyopathy. And we were able to actually direct him to a Pete's cardiologist in the hospital.
So he had HOCM, right? I guess is what you're saying. So he had HOCM, but maybe his trope was probably negative.
Yeah, I don't even think they sent it.
Yeah, because he was young.
The syncope, the echo was helpful because he would have gone to a community ER with no Pete's cardiology, and they would have just send a troponin, send a test, maybe that did an unnecessary head CT, and then send him home.
Right. I mean, Chris, you're still a resident, right? Don't you see people ordering head CTs and carotids on syncope? It's craziness. Listen, I'm all for doing it. You just got to prove to me why. Well, the guy can't move the left side of his body. You got me. Good, right? But you didn't need the guy to pass out to tell me that guy needs a head CT. And by the way, he if you want to get an MRI, because that in some hospital, in somewhere in the world, because that can be done in 2 minutes in your hospital, get an MRI. I don't care. Right?
It still seems like that's cutting edge to not do it, because they'll suggest not doing it, and then you'll go back and amend your orders to include the head CT.
And by the way, I'm a big believer that if you're going for a head CT, you probably need a CTA no matter what's wrong with you. The neck Northeast Cerebrovascular Consortium has been saying that for years. If I'm bringing you to the imaging table for a head CT, you probably need a CTA before you get off the table. Always, right? Whether it's an intracranial bleed, whether it's a stroke. I guess you don't need it like if it's, you just a small bump on your head, right? But if you see blood, then you need a CTA no matter what, right? And if you have real neurologic symptoms, NEC has been saying for years, though not everybody's doing this, some people are doing this routinely. Some pre-hospital stroke trucks are doing CTAs routinely with CT heads, But yet if you show up in an ER, some ERs only do CT heads. It doesn't make any sense. It's like you figure out the problem without figuring out the cause. To me, you're not looking at the vasculature. I don't understand, why you don't do that, right? Any thoughts on that? No. All right. Interesting pre-hospital calls.
Yeah, I had a couple. One case was a young, probably about 40-something-year-old female, found unresponsive at home by her mom. Mom said that she really weren't able to get much history from the mom at the time, but basically was complaining of some headache earlier in the day, and took some Excedrin, and then later on went unresponsive. So when we got there, we had found her already in the BLS ambulance. She was not really responding at all. Went to put an IV on her. She had some minimal responsiveness to the pain. We were kind of going through a differential at this point as to what was going on. She had, her blood sugar was fine. Her vitals were actually pretty much okay. Her blood pressure was 120/70 or so, and her heart rate was about 48, so a little bit bradycardic, but not out of the realm of where someone could be normally. So at this point, we were, the fire department there thought that maybe she had been shaking a little bit, so we were kind of, waiting it out a little bit to see what was going on at this point. She was definitely out of it, so we were thinking at this time the sugar was kind of ruled out. with the blood sugar that was normal. So at this point, we were kind of thinking maybe she had a seizure and or possibly brain bleed. So, the question is, how quickly do we intubate this person, or do we need to intubate this person at this point? Her vitals are all fine. She's maintaining a saturation, just a little bit bradycardic. As we were getting more and more information, from our clinical exams and everything, after about 10-15 minutes of being on scene, she really had no improvement whatsoever. Went to put in a second IV. I noticed like a little bruise on her arm, which looked a little bit strange to me, but nothing else really that I saw. And we obviously didn't, completely undress her in the back of the ambulance. But after about 15 or 20 minutes, we decided that, less likely a seizure. She really hasn't come back at all. Mental status has been exactly the same. Pupils were small, but reactive, and we tried Narcan just in case. As around our areas, we do see a lot of heroin overdoses, so to give it a shot is always worth it, I think, with very little harm. So we ended up intubating her and brought her to the hospital. When we got to the hospital, we found, she had a huge brain bleed, basically. That was intraventricular, bilateral. And then upon, after being in the hospital, I hung out around the hospital for about half hour, 45 minutes, kind of just see the workup. Our platelets came back at 8.
8,000.
Yeah, 8,000. I don't know what her white count was. But it turns out that for the past 10 days or so, she's been complaining of some headaches and had this bruise on her arm, which we noticed, and then also had some bleeding from her mouth that various times didn't really get checked out. It turns out she had undiagnosed ALL, basically, and they started transfusing her with
How old
platelets
is
at
she?
the time. Young 40s, 42, 43 years old, something
So
like that.
we often think of ALL
Yeah.
in kids. I think there's a bimodal distribution for ALL, if I remember right. It's 3 to 5, and then there's 7 to 11. Somebody will correct me, but is that
Cute
right?
little lad, so whatever that encompasses.
A cute little
That's
lad.
how you remember it, right?
So 3 to 5, and then maybe 7 to 11ish. Is that right? But it's that distribution in childhood. Yeah.
So she had that. She ended up actually herniating and passing away within like 24 hours or so.
And ALL usually in kids does really well,
Right.
So probably in her age does well for most people too. I mean,
Yeah.
AML is the one you worry that's really bad, that needs bone marrow, and it's a bad disease.
Yeah.
But her complications of it was terrible.
Yeah.
I want to say she must have had symptoms before.
Yeah,
like
so it sounds like for at least 10 days there was some stuff going on,
Yeah.
which she didn't get checked out. But and this was I found out after I was already in the hospital. But she had been complaining of some headaches over the past 10 days, and then I'm thinking, all right, so now this lady, let's say she came in 10 days ago complaining of a headache. At this point, who knows if she would have had any neurological deficits at that point. Maybe her headaches were related to. I don't know what was going on the last 10 days, but, just trying to think if I would have scanned her, I talked to the ER doctor there, I'm like, if she came in 10 days ago complaining of a headache, would you have scanned this woman? And she's like, I don't know, maybe. And I also, I don't know, maybe I would have scanned her, maybe not. But, who knows if we would have noticed these bruises and other stuff. But, the amount of headaches that we see are like, most people are not getting scanned with
If she
headaches.
doesn't have headaches, you can't scan
Right.
everybody. But we certainly would all scan. It's like when they come to their third ER visit and somebody says, let's do a
Right.
CAT scan, and that person is brilliant and everybody before them is dumb. But
Right.
if you bounce back 3 times, I'm probably going to order a few more
Right.
tests, right? It's not.
Right.
It doesn't mean you're any smarter.
Right.
Maybe even your second bounce back for headache. Somebody told me years ago, your worst, first, and longest headache should always get a CT and LP.
Yeah.
Your worst, first, and longest headache should always get a CT and LP.
Yeah.
Of course, the CT scans for subarachnoids are getting really, really good, and I firmly believe in your generation, it will be a day where you don't have to LP anybody after a CT. The CAT scans
Yeah.
will be, whatever generation we're on now, will be that good that you won't have to do it.
Yeah.
What are your thoughts on getting a CTA?
Yeah, I think that's okay too. I think it's not perfect. I think an angiogram is still a better test, but angiograms are not completely benign tests, and CTAs are pretty benign tests in general. So I think that's fine. You should do angiograms to everybody, but I think CTAs are okay. The literature is just so freaking complicated to me about what's a positive tap. You have some people some neurosurgeons in the world who will say, every time the ER calls me with a bloody tap, I do an angiogram. The angiogram's always negative, right? And I've had people who say, I know it was a clean tap and blood came out, and I knew this was a subarachnoid, but when I did an angiogram, there was nothing found, and the HSCT was negative. And how many red cells is really abnormal? I think we're kind of all over the place.
Yeah.
I think a CTA lessens the likelihood if you're still strongly suspecting it, which probably is a very rare thing nowadays. You know, it's probably reasonable to do that LP. You know, I mean, I don't know. What does everybody else think?
You can have aneurysms that aren't super apparent that still bleed. They might not be a saccular aneurysm that causes the hemorrhage, and it could be missed on a CTA. So you get lulled into a false sense of security that it wasn't actually a subarachnoid in the first place.
Right. So
And
what about
I
a
don't-
CT, CTA, and then an LP? Because if you know,
that's also been discussed as far as the LP being bloody or not. If you get that LP on a subarachnoid very quickly and they spin it down, there may not be any xanthochromia, which is
so your point is the timing. I mean, do you believe in a 6-hour time limit of when an LP is helpful and when it's not?
I think we have pretty good evidence that, like you said, the generation of CT scanners we have right now.
So if you have somebody who refuses an LP, you do your CT is negative, they're the worst headache of their life, so you're worried about a medical subarachnoid, they get a CT and then they refuse the LP, will you send them back for a CTA?
I've done that. I've actually
Yeah.
done both at the same time
Because
sometimes.
I'm sure you've got a lot of people, or a bunch of people who've refused LPs over the years, right? So
Yeah.
now, maybe that will help you a little bit more and just get a CTA,
I've done that many times, where I just CTA.
because they refused the LP, or because,
So the last case that I had was a kid who came in as a third visit, and he was coming in for a migraine headache. Appropriately treated the first time. Well, the first time he came in for like a little strep throat or something. Then he came for like a migraine headache. Then he came back again for the same thing. He was like 19 or 20. Came in again for like a simple headache again, not persistently kind of getting worse. And so I'd CT and CTA him, just because it's been ongoing now. And the CT is gonna, it's not gonna, decrease my likelihood. I still have to get a tap on this guy, but if I got like an aneurysm in this kid,
right,
the CTA, then I've got an answer at least.
right.
You know,
If you can get MRI, MRA, we could do that instead.
if I had that availability, the likelihood of it,
We had a student a few years ago at a different hospital who had a worst headache of his life, then it became the longest. And he didn't look like he was in that much distress, but got a CAT scan, repeated CAT scan on a second visit, refused an LP both visits. Finally, the third visit, I got the LP, and he wound up having TB meningitis.
Wow.
And but he didn't look in that much distress, and it wasn't that it was his worst, although he did say that, it was that it was his longest headache, right? But if you come in and you're 80 years old and you say, I've never had a headache in my life, and you have a headache today, the question is, do you do an LP on people? And we all get wooed into like, well, the guy looks so good, why tap him? And I get wooed into that too. But the other thing is, there have been articles written about, well, if you give somebody Dilaudid and the headache goes away, does that mean you shouldn't tap them because their headache is responsive, or subarachnoids aren't any less or more responsive to narcotics? So if they look terrible when they came in, no matter how good they look, you probably should tap them. Although I must admit that if somebody looks like $1 million after narcotic, I probably am less likely to do an LP, but I don't think that's the right thing to do, right? Any thoughts about that?
Yeah, I mean, I had an attending in during residency who said the only headaches on a scanner people that basically look terrible. I mean, are vomiting or just look terrible. And, yeah, I think these are always tough, and it's so subjective as well when you talk to these people and you say, and you try and really ask them how bad is the headache. Well, it's the worst headache of my life, of course, because I'm in the ER for it. But, is it really the worst headache? And I think when we kind of really tease it out with them, sometimes we can get a little bit more information. Spending a couple extra minutes with them and really trying to get the history of the headache may be somewhat beneficial. But yeah, I think it is a tough call because a lot of times we do just get a head CT, and the evidence doesn't say that that's enough at this point, especially after 6 hours. So, if we're really looking for a bleed, then are we going to do half a test basically, and then not continue on with the rest of it, or are we kind of obligated to offer that? And people like maybe it's a little bit of an annoying procedure of what it takes time, so we say we don't want to do it.
Right.
But if that's what we have to do, then that's what we have to do.
But I mean, I've gone to the bedside. I remember a patient who got signed out to me, and it was only 2 hours they were having their symptoms.
Yeah.
They said it was the worst headache of their life. They got narcotics. They got $1 million, and the head CT was negative. And the patient looks at me and says, "Do I really have to get a spinal tap?" And I'm thinking, it's 2 hours since your symptoms started. The case was just signed out to me. I mean, what's the right answer?
Yeah, I mean, I
No.
think within 2 hours,
No.
if you have a negative CT,
Go
you
home.
probably don't. Yeah.
Right.
And I think what's silly about the worst headache of your life thing is, by definition, every single one of us is going to have a worst headache
Right.
of our life at some point.
One day, and right.
I don't ask that question anymore.
You don't ask the
No,
question.
I stopped asking it.
I agree.
Because everybody always says yes. Like,
Yeah.
I mean, you can just guarantee somebody is gonna. I mean, people are always gonna try to kind
Because
of.
what we're saying,
oversell.
by the way, is if you go into the ER and tell the ER doctor you have the worst headache of your life, or me worst, first and longest, they're probably going to get a CT, and that will be followed by a spinal tap.
Right.
I mean, the easier question to ask is, when was the last time you had a headache like this?
Yeah,
And
that's
that's my
more
way.
important. And is this normal headache for you? How is this different? Like, what were you doing when this started? Those are all more important and more valuable to me than is this worst headache of your life. Because people are always going to try to oversell their symptoms. And that's not a bad thing, but somebody comes in with a cough, and then you say, have you had a sore throat, runny nose, any, fevers? And they're like, oh, yes,
everybody's
yes,
had
I've had
fevers.
that. It's like, okay, this is a virus. They're like, but I'm not getting antibiotics. I'm like, no, you have all these symptoms, it's probably a virus.
Right. That's always the answer. It's viral. It's viral. It's viral.
Right, so,
God for
I don't know.
viruses.
Yeah. I always say that I'm happy to give you antibiotics for your viral infection, but nobody ever laughs at that joke.
Yeah. And I try to explain what a virus is and how it's different, and we have no medicine to kill it. Whether or not you believe the CDC and their backing Tamiflu, I mean, we can. That would be another.
Well,
great
one of my old
discussion.
mentors, Jake Kaplan, used to say you have to figure out what brought them into the emergency department, and was it they came in for antibiotics, and you have to address that, because if you don't, they'll go home unhappy.
Right.
Right, but Tamiflu. So we know Tamiflu is not a magical drug, because everybody has the flu now, right? This is in all the emergency departments. The flu shot depends upon who you read. The last thing I saw says it's 23% effective. Who knows? I mean, it's not incredibly effective. That's all I can say for sure. And Tamiflu helps in one study by 1.2 days, another study 1.4, another study less than 1 day, right? So it helps you very little, and the side effect profile is terrible. About 50% of people will get nauseous. Somewhere, depends upon whose paper you believe, about 25% will throw up from it. So I usually say to people, based upon all this, do you want the drug? So a lot of people say yes, but if you don't give it quick enough, preferably within the first 24 to 48 hours, you're not going to help somebody at all. And even if you give it right away, you're only going to help somebody by about a day.
Yeah.
So not that much. But listen, I was telling you guys before, a few years ago I had the flu and I had 104 and I knew it was coming on. I'm like, this is really bad because I can't be out of work like most people.
Right.
And I got Tamiflu, and I knew but when you're 104 and you're a little delirious,
Yeah.
you'll take anything.
Exactly.
And of
that's-
course I started to throw up. And then I'm like, am I throwing up because I'm sick, or am I throwing up because I took the Tamiflu and I stopped the Tamiflu and I stopped throwing up? And then I basically just went to bed. And listen, I got the flu shot, so I think my course of my illness was a little bit shorter than most other people. But everybody has the flu now, and I think besides
I have that same discussion with patients that you have, and ultimately most of them will end up taking Tamiflu. If I discharge them with Tamiflu, they're usually getting a prescription for Zofran for a couple days too. But it's funny because I think everybody's kind of adapting to that discussion style, case-by-case scenario, and not really recommending against it, not recommending for it, because the CDC is really recommending that we treat now, even without testing. So it's funny because I called the pharmacy because they said, look, we're out of Tamiflu. So even if you prescribe it, we don't
Right.
have any left because all the pharmacies are running out of it. So,
But despite that recommendation, I saw Anthony Fauci on a thing he did, and he was he presented the data, and in his presentation he said, although we are recommending this, here's the data, and he presented how terrible the data was supporting Tamiflu.
Right.
Despite that, everybody gets Tamiflu in a Z-Pack, and we're probably helping almost nobody.
right.
All right. Or then we tell them we have bronchitis, and bronchitis is a completely made-up term in medicine, right? Nobody agrees with the definition of bronchitis is. It means I got an X-ray, I didn't see too much, so I'm going to give you a diagnosis. You can go tell your family members,
Yeah.
right? Otherwise, we don't know what bronchitis is.
Upper respiratory infection.
But I know it's codable.
Yeah.
Any other interesting cases?
I mean, hospital
How about in the ER?
in the ED. I mean, it showed pretty much what sounded like a classic pericarditis. I know we talked last week about evolving EKGs are never a good thing. A gentleman with mid-60s, diabetes, hypertension, diabetes, high cholesterol, with sharp chest pain just in the middle of his chest, kind of epigastric region radiating to his back, got better with Tums. Worse when he lies back, better when he leans forward. Sounded like a pretty classic pericarditis case. Is kind of what we thought. Initial EKG just kind of showed some diffuse elevations, very minimal elevations throughout. No reciprocal changes. He got a GI cocktail, felt better. Got labs back. Troponin was elevated about 15. Went to check on him. He said his symptoms were starting to come back. Repeated a 12 lead, and now he had pretty clear evidence of a inferior STEMI. So, kind of going back to what we talked about last week, was just repeating EKGs. The dynamic EKG changes is never a good thing. He ended up going to the cath lab, had 99% RCA and 90% LAD. So got stented and ended up doing well, but I think he was very atypical, diabetic guy, very atypical symptoms, but
Yeah.
it was real.
Yeah,
So, so that was just very interesting. It was kind of learning, I guess, teaching points there. We're just continue to reevaluate the patient, repeat EKGs, put the whole picture together. Diabetics will present atypical.
So, Mike, I remember when you were a fellow, we reviewed an article that said, I still remember you quoting, the bigger your troponin is, the bigger your infarct is. But you told me you were taught in residency that that's not true, that a higher troponin doesn't correspond to more infarct size. But then we reviewed an article a couple of years ago that said there is a direct correlation between how big your troponin is and how big your infarct size is.
That was the one where they did the cardiac MRI.
Yes, so it was a
Yeah.
really good study. So I believe that the bigger your troponin, the bigger your infarct is. But what do
Well,
you
maybe
think?
the question is,
Because we don't do a lot of cardiac MRIs,
Right.
right? And
oh, every day you don't.
Right, every day. But that's a pretty good endpoint for their study.
Right, I agree. So I guess the question is more, does the level of the troponin correlate with the patient's outcomes, I guess? Because you could have a sizable infarct in one part of the heart that
It doesn't affect your EF too
Right.
much because it's a different wall.
So maybe
right?
that's what they've been referring to in the past, as far as what I was taught, as far as troponin levels doesn't necessarily correspond
Well,
with
so I guess
the-
that makes sense. So the question, I guess, is does the higher troponin correlate with worsening outcomes? And I'm not sure I know the answer to that. I don't think that's true because I keep being told by people I know who are interventionalists about tropes of 50 to 100, and they cath them and it's clean, and they diagnose with myocarditis,
Mhm.
right? So I keep being told over and over, hey, Mark, that patient we just took trope of 80, this was just a couple of days
Right.
ago, and the cath was perfectly clean, sent them home with myocarditis, who knows, but maybe it was vasospasm, but probably not because the echo was perfectly normal, and I did TE to make sure. So I don't think that would be the case because of all those myocarditis cases thrown in. And obviously myocarditis can completely mimic STEMI.
Right.
where
You can
go
still,
on.
and even I know STEMIs that I've followed up on, I see troponins go, it could be an assay difference, but ours will cut off at 200, and I'll see values that are off the charts, just reported as greater than 200, and they'll still have a pretty decent preserved EF on.
Right.
on
So who
discharge.
cares where it is, whether if it's preserving? We all have done myocardium after our infarct. So what's going to be like in a couple of weeks? That's why all the people get life vests, right? And I'm just having a flight of ideas. So you told me that you're attending at when you did a residency, didn't get CTs on people who didn't look sick. But I remember my first case was somebody with a big subdural, an old guy who was sitting on the edge of the stretcher, looked like $1 million, barely had a headache, and because it was a bounce back, I scanned his head, and he wanted to leave before I could get the CAT scan back, over and over and over again. And I mean, don't you guys remember your first patient who looked like $1 million with a big bleed, and you go, it must be the wrong patient?
Yep.
And the thing is, like, subdurals are trauma, right? But when you get old, because all these emissary veins become unstable, you can sneeze hard, and get a subdural, right? That's why old people get them because of lack of compliance to emissary vessels, right? So,
Didn't Dan
Shear-
have one? A young person who sneezed and gave themselves
a subdural,
a bleed.
Yeah.
right?
I remember.
So you can have anything being old. You can have almost anything else. But most of these subdurals don't go to the OR, or not that clinically significant, unlike epidurals, and do fine. But of course, if I was that attending, who's somewhere maybe watching this, I would argue that does it really matter if I'm missing some subdurals because they're getting reabsorbed and they're doing okay? So he says, I bet I do miss. I bet we all miss bleeds, and they go home and we find on their CAT scan they have encephalomalacia. And we say, have you ever had head trauma? And they go, yeah, I hit my head, but nobody ever did a CAT scan. And you go, I bet this person had a bleed, but it wasn't clinically significant, so does it really matter?
Yeah, and it may be even worse to find out that they have these small bleeds. And what additional testing does that get them to? Where do we go with that? I mean, for example, yesterday I had a patient who was sent in for, the guy was complaining of dizziness and said every time he turned his head to the left or something, he got, very dizzy, felt like the room was spinning. It sounded very vertiginous to me. Then he said, he was also having a little bit of chest pain and some shortness of breath, and his pulmonologist sent him in for a scan of his chest because he had a PE about 11 months ago in the setting of being in a cast. And he thought that maybe this was a new onset of another PE. His INR was
His
therapeutic.
dizziness?
Yeah, the dizziness, because he presented as dizziness last time, although looking through the chart, it was really much more. He said, every time I was crutching around, I got very short of breath. I could only go 5 steps or something, and then they did a D-dimer, which was elevated. I'm thinking that this guy's got vertigo. Then, the pulmonologist calls. He says he wants a CTPE. I wasn't going to order it originally, and I'm like, all right, I'll get it.
Because he's a
You wanna do it.
pulmonologist. The cardiologist would have wanted
Right.
the stress test, and the
Right.
the hemonc up would have wanted an H&H.
So I order it, and then sure enough, this guy's got a tiny little PE, which can be seen on one slice of the scan.
And it was probably
And-
artifact and overread by a resident or something like
So,
that.
and they even put an arrow on it to show you
It was
where it
subsegmental,
was.
which we would have missed years ago.
Right, so they said there's a small filling defect in the right upper lobe. Appears to be chronic, but could possibly be acute.
That had nothing to do with the guy's dizziness.
That had nothing to do with the guy's dizziness. But now I gotta tell this guy that he has a PE, so he's like, oh, I knew I had a PE, And it's literally like.
And you're
tiny
thinking,
thing.
not only did you not have a PE, you didn't have a PE last time either.
Right. So, now he's got this, and now he has this finding. He's therapeutic on Coumadin. Now they want me to start Lovenox on top of the Coumadin, or heparin on top of the Coumadin.
Well, if he's therapeutic
Coumadin,
Coumadin, does he need a greenfield filter?
Right, so-
Which will only be good for a short period of time anyway.
Yes, I'm like, now we did the scan. We found this thing that's, 5 millimeters or whatever, and is it really explaining the dizziness and his chest pain on the left side? I don't really think so.
Your
But
PE was
now we
on
have a
the right,
diagnosis that
sir.
we're going to hang everything on. Probably
And
not
we all
look for
know the
anything
worse the
else. I'm
patient's
like,
dizziness, the better you as a healthcare provider should feel. The more subtle the dizziness, the worse you should feel. Subtle dizziness is cerebellar until proven otherwise, and bad dizziness is something a more peripheral lesion,
Yeah.
right? So when the patient's vomiting and can't move their head, I walk in the room going, I feel better, nothing
Right.
bad's happening.
Yeah.
They don't like it when I tell them that, though.
Right, because they're throwing up. So,
Those
so
are the perfect
what?
patient to do Hintz exam on.
So-
A Hintz exam for cerebral disease.
Yeah.
So, I'm just curious. If this? Peripheral
So-
PEs we're sending home. So did you send
Oh,
us?
no,
back?
they wanted him admitted because he now has an acute.
Oh well, of course your guy's
He's got
different
an
because your
acute
guy was on
PE
Coumadin.
Coumadin, which
Right.
is like this tiny thing. They wanted him on the heparin drip. So he got admitted to telemetry. I checked on his chart this morning. He's on a heparin drip. All the symptoms resolved.
As
So
a GI bleed?
last night the note that they wrote, everything resolved, but heparin doesn't take.
Heparin doesn't get rid of your PE.
Right, in 5 minutes.
And plus,
Or
why does he need
hours.
heparin? Why can't he just get a 10A inhibitor or a
Right.
direct thrombin
So I think
inhibitor
they were gonna
orally
maybe
and go
transition
home?
him to that.
Because we can send PEs home,
Yeah.
right? There's nothing wrong with it. Have you guys sent PEs home? Have you sent PEs home?
Yeah, all the time.
Yeah. Yeah. And
Yeah.
well, yeah.
And then the medical shows also the family was very concerned that he was going to die because they're like, everyone dies from pulmonary embolism based on X, Y, and Z TV show.
Right.
And I'm like, well, there's plenty of people walking around pulmonary embolisms that don't die. There is this, small subset of people that do die from it. They're like, no, everyone dies from it. I'm like, no, it's just on TV.
No, right.
But, yeah.
All right. Anything else interesting in the ER?
Sticking on the PE thing, I'll just make it quick. 'Cause I know we got to go to articles, but a lady with persistent cough for 3 months, kind of just past week or so, just shortness of breath got a little worse. She's seen 3 different providers, gotten Z-Packs pretty much every time. Was on day 5 of Z-Pack number 3. Still wasn't getting better. Shortness of breath was a little bit more concerning. Her grandson made her come in, and
So far it's just terrible because
Yeah.
when people say I need something stronger, right? So anybody who says I need something stronger, it makes no sense. You have antibiotics to cover certain bacteria. There's no such thing as stronger, right?
Yeah.
It's all just what you're covering. And 3 Z-Packs, the healthcare provider should have said after the second Z-Pack, which probably wasn't necessary,
Correct.
what am I doing wrong?
Yeah.
Right.
Well, she did get Tessalon pearls added to the last one.
She got Tessalon pearls.
Yeah, so that.
I
Forgot, did they give steroids?
Yeah, no, she didn't get steroids
That could be the problem.
somehow.
Did anybody check for pertussis?
No one checked her
Which
for
is
anything.
everybody's writing about adult pertussis.
Yeah. So the shortness
Yeah.
of breath is what concerned her. I was going to scan her chest to look for her cancer that I thought was there, but instead I found a PE in the right main pulmonary artery. That was her shortness of breath.
Yeah.
So it was just.
Which
I mean,
didn't get fixed by 3 Z-Packs.
No, it did not. Surprisingly, I was going to write a case report if it would have gotten fixed, but unfortunately.
So, and if her CT was negative, I assume you would have. I mean, hopefully you picked up the echo machine and just looked at her heart, looked for
Yeah,
her
did with the
heart effusion
resident.
and
Mhm.
stuff like at bedside, and then her lungs really quick, and then you CT'd her.
Yeah.
And I guess if what would you have done if her CT-PE was normal?
Her vital signs were all pretty normal. I mean, she was going to need. I mean, she was an elderly lady, so I mean.
Was she short of breath too?
She was short of breath, mostly with exertion, and this was new for her. I was probably going to put her in the hospital and get a little bit further. Where she would need probably
Yeah.
a formal echo.
The hospital RDU, formal echo, and she was how old?
She was 80s, mid 80s.
She was 80. You can argue like she's good for like Alexa scan,
Mhm.
right?
Yeah, and she's never really had any workup before. She said her only medical problem was hypothyroidism, and that was it. Otherwise, she doesn't. She takes.
Did you
it
check a
simply.
TSH?
I did not check a TSH.
Ah.
I know we were talking about it. I
Yeah.
didn't. So it was just interesting. I had a resident. We started off with ultrasound at bedside while we were talking
Yeah.
to her, and the heart looked great. I mean, good strong contractility. There was no effusion. Lungs looked clear. She sounded clear. That's why I was like, what exactly is it? And
Who just told me to get TSH in everybody? Segura?
Everyone.
A TSH in every, right? Not the ankle sprains, but
Right.
if you make it to the main of the ER, are you getting a TSH with you?
I mean, not everybody, but I mean, I think it's very underutilized diagnostics lab exam that we do. I mean, of all the tests that we do, the CBCs that we, order on everybody that comes to the door, I think we underorder.
Some unnecessary.
Sure.
Yeah.
We underorder the TSH.
Right. All right, so I agree with that. So you're saying that despite people's thought process, a CBC and routine electrolytes is a very low yield.
Right.
And TSH may have a higher yield than some people.
Sure.
I would also argue that for everybody who feels they have a little lump at the side of their neck, which is a lot of people, which is a little lymphadenopathy, which is probably not non-Hodgkin's lymphoma.
Right.
And the answer is to just wait, and if it doesn't go away in a couple of weeks, call me back.
Sure.
You could get like an LDH and bilirubin on them, and that's got much better sensitivity for lymphoma than because it looks for hemolysis, and that's much better than getting a CBC on people.
Right.
But people don't do
But
that.
people don't do that at all.
Right.
So I mean, elderly especially, the generalized weakness. Those are patients that I can order. I told you about my case where I had she had flu-like symptoms. She was febrile 103, but she was tachy at 145, and I just didn't really chalk up the tachycardia, that significant tachycardia, to just a febrile state. I ordered a TSH, and her TSH was non-existent, and she ended up going to the ICU for thyroid storm.
Right, but thyroid storm, I mean, isn't thyroid storm like a 45-point scale? I forget the name of it. It's a whole complicated thing, right? I mean, thyroid storm is an incredibly rare disorder.
It is.
Right? I mean, you see all these people who are non-compliant on their meds, and they're sick as can be, and they still don't have thyroid storm.
So a person who's got no
Anybody remember the
history-
name of it? It's like a 45-point scale to diagnose.
Birch-Warkowski.
Is that it?
Yes.
And it's like a 45-point scale for the next journal club. Why don't we just discuss the thyroid storm scale?
It's on MDCal.
It is.
Yeah.
All right. Did you calculate it on that?
I did not,
You did.
actually.
That's all right.
You treat it clinically.
All right. Let's go to the articles. So, how long should you resuscitate somebody for? Chris, you can tell us the answer to this. Everybody asks this
Yeah,
question.
No longer
one-liner.
than 26 minutes.
All right.
So this is a paper in resuscitation, duration of cardiopulmonary resuscitation in patients without pre-hospital return to spontaneous circulation after out-of-hospital cardiac arrest. So they're looking at a large cohort of patients here, 420,000 patients. This is a Japanese study. They're capitalizing on the fact that in Japan, all of their codes get transported to the hospital, as it's apparently illegal there to pronounce anybody in the field.
What
so
happens if you do? You go to jail?
I think so.
They have all these great Japanese studies that we're reviewing.
So that puts them in a unique perspective to kind of examine this, whereas patients that we're presenting either over the Medi-Control phone in the field or during termination of resuscitation, all those patients are getting brought to the hospital. So as a result, they're able to kind of stratify all these patients, break down the data, take a look at response times, length of CPR, and all these other factors. So What they looked at here was the 1 month CPC, so survival to hospital discharge with a 1 month CPC score of 1 or 2. And then they further
Do you know what that
subdivided-
means, by the way? Because we're using CPC scores on everything. We use it on the Mike's prep study. We use it on the DSD, the double sequence different relations. You know what that means, CPC?
So 1 would be like a good neurologic recovery or limited impairment.
5 is dead.
And,
I
yeah.
understand.
And then 2, subsequently
Which
increasing all
was,
the way down.
right.
So 2, I think, is like some moderate disability, but still functional.
Okay.
So they're looking at a couple of, well, they end up breaking it down into a few groups. 4 groups, they say, with 3 predictors. So patients aged less than 75 with an initial shockable rhythm, those aged greater than or equal to 75 with a shockable rhythm, and then those with EMS witnessed arrest and a non-shockable rhythm, and those with an unwitnessed arrest and non-shockable rhythm. So right there, just from the kind of categories that they're putting them in, we can see which is going to have the highest ROSC and highest in terms of favorable outcome. The patients less than 75 with an initial shockable rhythm had the highest 1 month CPC scores. It's a little over 6% for those patients. Then you look at the age greater than or equal to 75, but they had a shockable rhythm, 1.3%. Then they look at those with EMS witnessed arrest and a non-shockable rhythm, 1.6. EMS unwitnessed arrest and non-shockable, so 2 really unfavorable predictors, and they had absolutely terrible outcomes, 0.15%. Then they kind of break down, which was interesting. They go into the odds ratio about some of these different factors and its correlation to good neurologic outcome and survival. And so obviously age less than 75 had a favorable outcome, odds ratio of almost 3. The witnessed arrest, 2.6. EMS witnessed arrest, 3. An initial shockable rhythm is the highest, 4.37 odds ratio. And those are all the kind of things that we usually think about, right? I mean, somebody who's young, somebody who has witnessed arrest, somebody who has a shockable rhythm, all positive features of a resuscitation. But then the interesting stuff is that they actually charted or figured out the response times and the time that they in total got CPR for. And they looked at the odds ratios to compare those variables as well. So per 1 minute in EMS response time, odds ratio of 0.93. So with an increased time for EMS response, there's a decrease in outcome.
So say that one more time, because that's very important. Just say that one more time.
So with increasing response time, there's
By
by
how long?
EMS.
By how many minutes?
By every 1 minute.
For every 1 minute increased response time by EMS, there's
a decrease in neurologic or neurologically intact survival, and the odds ratio, and that's 0.93. So then you also look at
that's an argument for putting up more ambulances in the geographically correct locations where people are more likely to go into cardiac arrest, which we showed in an earlier paper was probably around nursing homes or where more elderly people live.
And then they look at maybe something that you have less control over, but pre-hospital CPR duration, in terms of them. I mean, again, they're not probably staying and playing so much in Japan because they're transporting all these people to the hospital. So even if they triage and there's unfavorable prognostic indicators, they're still going to be transporting these patients. But pre-hospital CPR duration per 1 minute, the odds ratio is 0.94 for a more poor neurologic outcome per every 1 minute. And the other thing as well, it's kind of interesting that they look at in this chart is advanced airway within this cohort as well, and that was an odds ratio of 0.88 as well. So something else, not a specific targeted study, but just something else that's interesting. That's another hot topic to examine as well.
So if you were designing an EMS system, what would you say about how long people should resuscitate patients for? Or can we extrapolate that information to the ER setting? Because we know simple things like if your end LCO2 is less than 10 after 20 minutes resuscitation, your chance of survival is 0%, right? But what can we say about just the duration of the code?
So the final thing that they did is they had this like regression model where they looked at and they found the specific time frame where the CPC score 1 or 2 in survival decreased to less than 1% in each of these variables. So greater than 26 minutes, like all comers, that was the longest that they would go. So even if you have favorable prognostic signs, greater than 26 minutes, less than 1%. And then 10 minutes in those with an EMS witnessed arrest, and 7 minutes in their last section, which was non-shockable rhythm. So I think 26 is the completely longest that they examined, even in absolute favorable conditions, with all of these favorable conditions being present in this cohort. Greater than 26 minutes, everybody's less than 1%.
So less than 1%. So does that mean you would design a system for 26 minutes for maximum resuscitation?
Well, I don't think it's that easy to tease out a specific, protocol to apply across the board. But I think that, especially in New Jersey, where we have resource poor areas where you only have one medic unit for a large area, I think the issue becomes not so much the patient, but the other patients who would potentially benefit or derive greater benefit from that medic unit who's tied up on scene working the code. So I'm not sure that you can make it be black and white after 26 minutes. You ship up and pack it in.
But let's say you have to pick
considered.
something, right? Let's say you have to pick a number.
So I don't think 30 minutes would be unreasonable.
Right. So the study didn't really answer that, we're saying, but going with 30 minutes, it probably has a poor outcome in general. Of course, then we have people with persistent VF whose end-tidal CO2s are 40, and we just go, now what do we do? Or we have people who are asystole, who are end-tidal CO2 of 40, and you just go, it can't be. You can't be asystole with end-tidal CO2 of 40, but I say, asystole, I'm not going to transport. But what about the patient who's fine VF or slow idioventricular rhythm who's end-tidal of 40? Maybe that's just happening because of good CPR. And then I just go, I don't know. I mean, to transport somebody with a slow idioventricular rhythm, now I'll look at the patient. The patient's 80 years old with a lot of comorbidities. I'll say, I know their end-tidal is 40, somebody's doing good CPR. To transport the patient, which will decrease that end-tidal CO2, and the ER is just going to say, why'd you bring the guy here? I would just pronounce him because there's no utility. But if now I make this patient 40 years old or 30 years old and they have something on the monitor, now I go, maybe they're a candidate for ECMO, right? But then I say, then I better bring them to a hospital that can do ECMO from the emergency department, which most hospitals can't, right?
Even the paper.
I mean, we know putting a balloon pump's not going to help because that only adds extra, half a liter per minute, to your ejection, to your cardiac index.
If only you had an EMS fellow to show up with like a portable ECMO machine, and then you could transport him to a capable facility.
Right.
Fair enough. There's an article about that.
I mean,
there's an article about that.
we all keep doing, we all keep talking about that, but it certainly has to be the right patient because even France and Germany studies about pre-hospital ECMO still have terrible outcomes.
And just like that cardiac arrest case review that you posted for this week, that was a perfect candidate, but it was a case report, right?
Well, we reviewed last week that you have to choose the right patient.
Yeah.
And this study, it looks like they're actually sorting out the proper way.
Yeah.
You're seeing witness versus unwitnessed because those are two different patients.
Mm-hmm.
Initial shockable versus non-shockable. Those are two completely different patients.
Because the best survivor rate, the survivor rate for people who don't get ROS pre-hospital in the biggest study published in circulation was 9%. 9% of people who don't get ROS in a pre-hospital setting will go on to be transported to the hospital, will walk out of the hospital alive in the biggest study. The number may seem higher than what we think, but that's the biggest study ever. And that 9% was based upon witnessed cardiac arrest, initial shockable rhythm, initial rhythm being VF, and then we added end-tidal CO2 being greater than 10 after 20 minutes resuscitation. Yeah, but it's hard to predict. Again, you're 40 years old. Maybe if you have any type of rhythm analysis and you have good end-tidal, and you have some sort of cardiac activity, which you may not be able to figure out pre-hospital if you don't have ultrasound, then you just transport them. But you do know when you transport them, for many people, that's a death sentence because your end-tidal CO2 is going to worsen.
Right.
So then there's the kind of perverse incentives of Medicare as well, which we can't totally ignore. I'm not saying that we make decisions off of whether or not we're going to get paid, but it's something that hopefully we one day fix. But one would say also you're expending all this time and resources, tying up a truck for 30, 40 minutes sometimes on scene to work somebody.
Not even one truck, sometimes two.
Multiple resources between BLS, ALS, supervisor out in police, and then you pronounce on scene, you don't transport, and then Medicare says you don't get to be reimbursed for anything that you just did because you did not transport, because they only pay for the transport.
Right.
So I don't think that's what we should necessarily be basing everything off of.
It's like
but
saying to an
it's-
ER doctor, you only get paid if you treat the patient.
Right. Or if the patient lives.
Right, right.
You know, so it's not the whole thing, but I'm sure it does factor into some people's
We should
decision-making
incentivize
overall.
good care.
Absolutely.
Right. Anything else, Chris? Okay. Mike, you want to do the echo? I mean, I guess the echo will preface by saying there are these new devices, and we don't support any devices that are. So we have a lot of different ultrasound machines. We like them all. There's this new device. It's not on the market yet, so I really can't comment about it. Although I've seen it, called the Butterfly IQ, which is supposedly a cheap, an inexpensive device that will be an imaging on your phone. We contacted them, and they're not ready for shipment yet, so we really can't comment about it. It is interesting because the rate limiting step for ultrasound in pre-hospital setting is that it's so expensive. If you have a large system like we do, we would have to buy 30 of them, and that's not easy to do. You'd have to prove to me that there's better outcomes in patients to decide that this is more important than doing other things. So we'll see what the final price is, and we'll see what happens when they ship them, or when they're ready to ship. But there's potential now for more pre-hospital crews to have ultrasound, which I think one day we'll all be at anyway. Right? We'll all throw away our stethoscopes in pre-hospital setting, we'll all be using ultrasound, and it'll be better patient care. So this was a nice review of echoes, right?
Yeah, I think this was a great article, so I just put it up on the screen so everybody can see it. It's also on the website. Echoes in Cardiac Arrest and Emergency Medicine Review. This was out of Military Medical Center in Houston, Texas. And they, we see echoes so much now in emergency medicine. It's readily available in every residency program pretty much. We're all using it regularly, and I think more than anything, we're using it in cardiac arrest. It comes in. It's really been, some would argue, a game changer in the realm of cardiac arrest, because you can see this article did a great review of all the different aspects of evaluating a patient in cardiac arrest, the different protocols. They kind of broke it down into determining outcomes based on somebody who's in PEA versus asystole, determining between PEA and pseudo-PEA, for example. So pseudo-PEA would be somebody whose heart is squeezing and perfusing, but just not well enough that you're detecting a palpable pulse. We talk about this all the time in Journal Club, like, should we be doing compressions on somebody whose heart is actually squeezing? And
This was the Littman paper that we always refer to.
Right. So POCUS, point-of-care ultrasound, is readily available. We're doing it pre-hospitally now. It's pretty much in every ER, hopefully by now. And it's increasing accuracy and confidence in clinical decision-making with cardiac arrest. So they reviewed a number of studies and a number of protocols, and the discussion was really the bulk of their paper. So they highlighted a few things. As emergency providers, a few of the main things that we're trained to do and we eventually are credentialed to do after residency would be, I'd say, first of all, is effusion. So cardiac arrest, we look at the heart, is there a treatable pericardial effusion? Have you guys ever heard this before? The picture that they show, figure 1, called the invisible little man bouncing on a trampoline?
No, so I haven't.
You've
Anybody
heard that?
You've heard of that?
Yeah.
So somebody told you that in an ultrasound course?
I don't know.
So you're supposed to say now.
because the RV collapses and bounces like a.
So you're supposed to say now. I can't believe you guys have never heard of that. I learned that like the first day of echocardiography.
That's one of my favorite parts of.
So it's called the
emergency
invisible
medicine.
little man on
The
a
invisible little man bouncing on a trampoline.
sign.
Sign. So that's figure 1.
Mike,
and
have you heard of that?
They have
I've
arrow
not, but
signs.
I love that in emergency medicine we name things as they appear, so it's not some
Right.
name of a person, like the Pepsi sign for the aortic
Mickey-
dissection,
Mickey Mouse
Mickey
sign?
Mouse, the Playboy bunny and
Yeah.
and liver. It's just
So apparently in pericardial tamponade, when the ventricle is being tamponaded in and collapsing, the diastolic collapse of the right ventricle looks like an invisible man dancing on a trampoline or something like that. But anyway, if you see that sign, that would be an indication that there's pericardial
We'll get one more chair.
tamponade. And we have obviously an intervention that we can do to pericardiocentesis or depending on the cause, maybe a thoracotomy.
So you can do a thoracotomy based upon the invisible little man sign balancing on a trampoline.
If the patient came in, in a traumatic cardiac arrest, we'd certainly consider it.
He's really jumping.
Again, just to see, explain to cardiothoracic surgery why he did it. You can say, well, he had
Invisible little man bouncing on a trampoline. Why wouldn't you? So let's see. So they talked about a few other things, readily available diagnoses that we can make quickly. For example, looking at the heart, seeing a pseudo-PEA, you can see if there's hypovolemia by identifying the size of the right ventricle. Looking at the IVC, if you're able to visualize it. Right heart strain or dilation would be the opposite if you suspect some kind of an increased right pressure acutely, like a PE or something like that. These things can all contribute to our diagnoses. Valvular dysfunction. So they go a lot into, they talked a lot about the position of the probe and how you're holding it, and how that actually makes a difference, because we tend to, there's some studies showing emergency physicians overestimate ejection fraction because of the positioning of the probe. So it's not really, we shouldn't be making calls about EF during cardiac arrest, is I think what they might conclude. But a lot of the times it's because we're getting a good look at the papillary muscles, and the papillary muscles are moving. That might be contributing to significant valvular dysfunction that we can identify maybe on ultrasound, but really that's going to make us overestimate the ejection fraction. So stuff like that, you don't want to get you don't want to get too detailed and kind of over-focus or over-think, because in cardiac arrest, this brings up the next kind of point of the article. How much time are we going to sit there looking at the heart when we should be pushing on the chest, right? So before I get into that,
So what about doing your echo during compressions?
so they mentioned one study in here, but doing see-through ultrasound during CPR. That's something that I tried to do in the field and in the ER. During CPR, just because a lot of the patients who are resuscitating have existing cardiovascular disease, and they're, with concentric hypertrophy, as time goes, the heart kind of shifts to the left. So you need to displace your compressions off the sternum,
Right.
And a little bit.
So that probably is the only utility of doing it, seeing where your hand should be for CPR.
Right.
Because your hand position is probably not where the American Heart Association tells us it should be.
Right.
Because of what you just said, the PMI gets displaced.
I had a case like that with Tabor, where I don't know if you remember, but you were able to get an apical view when we were doing compressions, and we had to completely shift over. I mean, we weren't doing anything with standard compressions in the midline.
Was there better outcome when
You
you
see-
shifted?
I think we did actually. I mean, it depends.
Ross, I don't remember
Some
the
cases
answer.
have actually had good cases, but you actually could see contractility of the ventricle when you start moving out.
Have you guys done this in the field? Have them
Yeah.
providers move their hands based
Yep.
upon
Yep.
All the time.
And do they freak out a little bit?
Yes, BLS does quite a bit.
Yeah.
It's out of their convention. It's out of their understanding. But then when you start showing, like look at this heart and see what it's doing now that you're moving over. It makes sense. It's an easy sell.
Right.
Once you point out that left ventricle, and then they see it start squeezing more as they moved over, it's like night and day. It's pretty amazing.
And have you ever moved so far over that you're actually off the sternum?
Yeah.
And if you're off the sternum, you have a greater chance of having a rib
Cracking
fracture.
ribs. Yep, that's what they're worried about. I think from.
And then is there a worse outcome because you're cracking a rib than not being on the sternum? I guess not, but I guess that rib could puncture.
Cracking ribs either way. Honestly.
Yeah.
Yeah.
Well, you are.
I am.
You are.
Well, how do you?
But we do know that almost every study shows body habits is associated with how deeply you compress.
Yep.
And how do you reconcile that with that article that we reviewed years ago about the mechanisms of CPR
Right.
between
Remember
the
that?
pediatric and the adult?
We should do that study. We should review that study again because that was really good. You liked that study, didn't you?
I love that study.
Yeah.
And so the thought behind that was there's two mechanisms behind CPR and how you get the blood restoration.
Right.
And you have the actual mechanical heart pumping, which is kind of the simplification of what everybody assumes CPR is doing, which is compressing the heart and kind of analogous to your cardiac massage during a thoracotomy. And then there's the thoracic pump mechanism, which is the increase and decrease in the intrathoracic pressure, which is then causing a venous return and then an outflow from the thoracic cavity itself. And they were saying through various animal models and everything else that it's felt that the mechanical cardiac compression is the primary player in pediatric CPR, but in adults that the thoracic
Right.
pump mechanism is the.
This is the claim to fame for the ITD, right?
Right,
So I
exactly.
mean, like, this is kind of what the push has been towards utilizing ITD and this type of resuscitation. Like,
But does the ITD work?
No.
In clinically?
Right, that it doesn't work. So we know,
Horrible
I mean,
studies.
we know that in the New England Journal of Medicine study, it didn't work, the biggest study ever.
right.
But the company would suggest that it does work based upon a subgroup analysis, which was published after that. However, in the subgroup analysis, if you look at it, it was only the people who had perfect CPR who had better outcomes with the ITD. People who had average or bad CPR had worse outcomes with the ITD. So based upon that, and based upon the fact that we're not all doing perfect CPR, I don't think we can recommend the ITD at this point.
Even based on their study, I think it was like a 9,000 N, and of the 9,000, I think it was like 1,200 or 1,500 of those patients actually had perfect CPR done. So with even their subset, they're saying that only close to 10 to 15% of their patients that they actually studied had good perfect CPR being done.
Right,
And so
right.
only in that subset of population are you going to see a benefit in the ITD. The remainder, 85% of patients who are not getting appropriate CPR are going to have worsening of outcomes.
So you would sell me on the ITD if that 85% had no difference in outcomes.
Right.
Then I would even go along
You
with
still
the
go with it
company
'cause there's that 15%.
because of that 15%.
Absolutely.
But a worse outcome,
That's
I
horrible.
can't get
Yeah.
it.
And now how can you sell a device that's saying when their data itself is showing that vast majority of their patients are having inaccurate CPR, and that margin was pretty wide. Like the margin for like compression was like 80 to 120. The depth was pretty wide, so there was a very large window to work with. Even in that window, they couldn't sustain appropriate CPR.
Right.
So it's it's not something that I would advise.
Right. All right. So
Sorry,
keep
no,
going.
we got a
Yeah,
little off
keep
topic.
going.
Yeah.
But yeah, so we don't endorse any product, or we don't remove recommendation for any product. So where were we? We were talking about echo, right? So the many things you can do. Other things just outside of the heart that you can do during cardiac arrest. Obviously, taking a look at the lungs, looking for tension pneumothorax, other treatable causes. It's just an easy tool, readily available. Everybody's being trained in it. One other thing that, or two other things rather, from this study I wanted to bring up. A recent study that I read that they actually referenced in this article was the ultrasound used during CPR associated with delays in chest compression. So this was an article that just came out in October 2017, and it was kind of a big deal. It was a small sample size of patients. I think it ended up being, it was like in the 20s or 30s. So not many, but there's a significant change in time, meaning patients who are getting POCUS or point of care ultrasound during cardiac arrest, CPR was interrupted by about 8.4 seconds on average, more than the group that was not getting ultrasound. And this was statistically significant. So we're
8-point-something seconds, and we
Right,
know that
so-
survival goes down by 17% for every 5 seconds you interrupt compressions.
in this group, the time off the chest average in time interrupted between compressions was 21 seconds.
Oh, so that's terrible.
So that's right.
So
Whereas it was
17
13 seconds in the non-ultrasound group. So that's something to kind of,
So I don't know how you fix that except you practice more.
or you do a TEE.
Right,
That's
you
the next
TEE.
point of this article.
Or reduce your pulse checks and go by the end title.
Right. Or see through CPR as best you can, getting a look, from an apical view or a subcostal view, so you're not going to interfere with compressions.
Who we just with that told us that in their ER they're doing TEs and cardiac arrest? Who was with me?
I was with you when you told me. I can't remember who it was though. Somebody.
I was just, we were in San Diego, and somebody in their ER said they're doing TEs on all their cardiac arrests, everybody. I can't remember who it was. Who out there is doing TEs on every cardiac arrest in their ER?
Nobody's commenting yet. That I can see.
So,
Keep an eye on it, but
what would it take for us to get a TE pre-hospital?
We have to have the correct
So-
code and the correct unit.
that's one of the things this article talks about. I mean, some of the criticisms currently is increased cost, right? Training. So The training that they recommend, they minimum of 2 to 4 hours of TEE specific training. We could do that. They recommend at least 10 proctor TEE exams. We could probably arrange that. And then you need to complete a standardized assessment to be credentialed. So assuming everybody could get credentialed.
That's for the hospital.
That's based on the current recommendation from ACEP.
So, can we
we were
buy a
talk-
TE and use one of our current ultrasound machines?
So we were researching it, and right now we're kind of stuck. So
Because none of our ultrasound machines can do a TE.
yes.
Yeah, I think TEE is still fairly restricted to the hospital. You need the big TEE video setup, right? I mean, you need there's no portable TEEs that I know of. Maybe there'd
So
be
nobody's
calls
doing
actually
TEs
takes place.
pre-hospitally?
Well, you can do it, but you have to bring a bigger machine. That's the thing.
Yeah.
So the Nanomax doesn't have a probe that you can do a TEE on. The IVIS doesn't. The
And again, we don't
Claris
recommend any particular,
Right.
ultrasound machine, but
The last time I
Get in
checked,
trouble for
Terrason was working on it, but I don't know if they actually have them yet.
the other things with every TEE, I mean, you have to take the time, like you have to, it's easier if the patient's intubated to get it in, but also you have to decompress the stomach, so you have to throw down OG tube before or during the
And I mean,
TEE.
you run into a lot of issues of
Um,
pre-hospital like decon. I mean,
Well, yeah, it's got to go to
Yeah.
sterile processing.
it's not really something that we can readily use.
I think in the ED, this is something that's completely feasible, and maybe we should be doing it. Maybe like routinely during cardiac arrest, everybody gets an A-line, everybody gets a TEE, whatever,
Right.
But
I mean, that's the argument with the A-line to see what your diastolic pressure is, maybe keep it at 40, but this is not associated with better outcomes.
Right, right.
Right?
That's the
I
thing.
get
That's
why
the
this
thing.
may be more beneficial, but
If the TEE was associated with better outcomes, or if there's some kind of, if it was really changing management, there's just not enough studies right now to show that the transesophageal echoes are superior or better than the transthoracic. The only thing that this article talked a lot about was the time you spend off the chest by getting a transthoracic view is affecting the survivability of the patient. So
right, so that's terrible.
TEE would therefore be a better option if you could do it.
So what should we teach ourselves to, when you're doing pre-hospital ultrasound, really focus that you're not doing more than 5 seconds?
What I tell when I'm with a student or BLS, I say you guys are in charge of the cardiac arrest. Every time we're off the chest, you start counting out loud. Once you get to 10, whoever you are, you start compressions again. So I let them run the code. And every student I have in my cardiac arrest, I say you're doing the most important thing. The rest of us are doing things that might help, but what you're doing is the most important thing when you're doing compression. So I say you're not allowed to be off the chest for more than 10 seconds.
Right.
And usually, if you put somebody in charge of it, they kind of take that responsibility and they're like, nope, you told me I can't do compressions. Oh wait, hold on, I have to intubate. Nope, you're gonna have to do compressions.
I think a collaborated effort is just certainly the key, and by that meaning, having the ultrasound probe ready when you're ready for that pulse check, getting ready to kind of have everything done. So as soon as you stop for a pulse check, your probe's already in place, either subxiphoid or kind of right where you need to be at that peristernal long. You get a quick look. You get if you see a systole, no cardiac motion at all, you don't have to look at the monitor because you already know what's going on.
Yeah.
But at the end of the day, being able to take a quick look, having everything ready, and that's kind of what we do in our resuscitation indeed. I make sure that this is a coordinated care. We're closing the loop. We're making sure that everybody's on point. Someone's looking at the monitor, someone's looking at the heart, and someone's checking for a pulse.
It's like the
And we
high
move
quality
forward.
crew
Right,
CPR where
exactly.
like when you're defibrillating, you're already charged and ready to go before you're off the chest.
Exactly.
Like
So
you're-
there's no point in
or
if you got someone who's got some type of refractory VFib, there's no point in trying to stop, taking a look at the pulse and saying, oh yeah, we got VFib again. You should already have that bad boy charged up, ready to deliver a shock as soon as you do a pulse check and get right back on that chest. That's the ideal way to do it. But that comes with, again, practice. It comes with, really kind of refining your resuscitation skills. And the more and more you do, the more comfortable you get, and the more and more you do, the better your process goes. And we're running the code at least.
Yeah. So Matt Harris is actually with us remotely, and he just posted a study. I'm trying to get it to load, but it looks like a pre-hospital, TEE article that he just posted from Sigma. So once it loads, we can comment on it. But
do we know where? Now, where is it from?
So
Is it a U.S. study?
So signaveda.com is the website. It's a journal in intensive care and emergency medicine. Looks like it's basically online. The abstract basically says growing evidence early detection response to physiologic deterioration can improve outcomes for patients working out of hospital. We often find ourselves in diagnostic dilemmas. So new perspective is kind of what we're looking at. And basically the article talks about utility of continuous capnometry and importance of point-of-care ultrasound and CPR. And it discusses the future of transthoracic and transesophageal ultrasound, point-of-care biochemical monitoring, tissue oxygen saturation, pupillometry, and mixed and central venous oxygen saturation monitoring in the pre-hospital setting. So it's an interesting article that Dr. Harris kind of posted.
So are they saying somebody is doing TEs pre-hospital?
It looks like they're commenting on multiple parameters and multiple diagnostic tools to utilize during out of hospital cardiac arrest, and they go into each one in quite some detail. In regards to TEE,
I want to know more about pupillometry.
right. That seems
That'll be the next toy that we need.
Right.
Yeah. I want to get TE on the physician vehicles.
So we can
Somebody
do it
help
with the
them.
Terrason.
We can do it with Terrason?
Yeah.
Oh.
We have two different probes.
And now you tell me Terrason's the only machine that you can do it at TE?
Only one that I know about. The other machines that we have just don't have the probe.
Can you get a price quote?
Yep.
All right.
Here we
Let's
go.
see if we can add
Yeah,
it.
there we go, everybody. So yeah,
But
so
just the unit itself.
that's
is
pretty much all the major things of this article.
Okay,
you
it
know.
sounds good. Let's go to the next one. Who's doing the next one?
What are we doing? Well, I really like the out of hospital extracorporeal
Yeah,
life support.
a second. I can do that.
All right.
You doing that one, Mike? or you want me to?
ACLS?
Either one.
I can do it.
Are we soon going to get like cards like ACLS? We'll keep our ACLS card behind. It'll be another
Yeah.
merit badge course that poor people have to take before they finish residency, and pre-hospital providers, despite still a positive literature that says it's the right thing to do pre-hospitally, but yet everybody's saying how great the outcomes are when it's not in those people.
Oh, but then we have the Dawn study too. We've got a lot of good studies.
Yeah, Dawn is good. So the ECLS study, or the ECLS case report, we'll call it. So this is coming, looks out of, I believe, Denmark or
This
Germany?
is meant for discussion because I know
Germany.
that
Yeah,
I mean, I
Germany,
usually don't
sorry.
put it in case reports, but it's always a good discussion.
Yes, this is a good discussion. So again, title of this one's going to be out of hospital extracorporeal life support implantation and cardiogenic shock after cardiac arrest. So it starts off by giving a report of a 62-year-old patient severe cardiogenic shock after cardiac arrest. The extracorporeal life support was initiated pre-hospitally. Patient was discharged with good neurologic outcome 23 days later. So pretty much the intro is saying that there's been a lot of efforts to kind of improve outcomes in cardiac arrest, even though there's been just historically poor survival rates, or you have a lot of distributed or distinctive shock afterwards, cardiogenic, other types of shock. Managing this in the pre-hospital setting has been difficult. So it talks about there are some specialized centers that are very specialized that can do short-term mechanical circulatory support for potentially treatable causes, and saying, is it really beneficial to transport patients to those facilities in the right setting? So this is kind of more food for thought than is it that is the right thing to do. And then it talks about going on about certain situations where you might need to consider where it's going to delay getting the patient out of whatever situation may be. This case report kind of talks about narrow hallways, multiple stairs, where it's going to delay actual CPR and resuscitative efforts because you're going to have to stop for so long the resuscitation to get the patient out of whatever location they're in. This specifically talks about portable ECLS devices. They speak of one we'll go talk about. So it says they report on the CardioHelp, which is their portable ECLS device. So just to kind of give a background on the case, reports a 62-year-old woman at home, thoracic pain. She had a witnessed arrest, collapse, went to cardiac arrest. There was no bystander CPR. 3 minutes after the call, the first responders arrived and started BLS. 3 minutes later, the professional EMS.
Sorry, we got a little disconnected for some reason. We got kicked off of the live stream, but we are trying to get people to go ahead and just follow the new stream, and we'll get people to follow us. So we might have to reshare the link, but it should be back on the page right now. So okay, people are following us now. So all right, we're back. We're good.
All right, so I'm not sure where was it the stream got kicked off, but we'll kind of start back again with the case, the resuscitation case. A 62-year-old female with thoracic pain witnessed cardiac arrest by her husband. No bystander CPR prior to to first responder arrival. There was 3-minute delay in BLS arrival. Then 3 minutes later, the professional EMS arrived, which the EMS in this description contained paramedics and an emergency physician. So a little bit different than the systems we're typically used to. Nonetheless, there was a VFib arrest. There was more than 30 minutes of an ongoing resuscitation, 13 shocks, 8 milligrams of epi, 450 milligrams of amiodarone, no improvement. And then this talks about the transport of the patient was not really suitable because of the location. And it was going to have to be be off of the chest and off of resuscitative efforts for a long time. It was decided at that point to activate the ECLS team, which from the Department of Thoracic and Cardiovascular Surgery, and that team was instituted to facilitate ECLS. Typically, they go to other hospitals, initiate ECLS, and then transport the patient. It's not necessarily a pre-hospital thing. So while the ECLS team was on the way, they did get ROSC. EKG was pretty much non-diagnostic. There was no STEMI. The patient remained in cardiogenic shock, high-dose pressors, maxed out norepinephrine. They tried mechanical ventilation, wasn't really getting improved SATs above 85. So about 78 minutes after the initial CPR initial resuscitation was started, 39 minutes after ROSC, the ECLS team arrived. The ECLS team, in addition to the emergency physician that was already on scene, had a cardiac surgeon, an anesthesiologist, and a perfusionist.
On scene?
On scene. So they assessed the situation, and they decided that that was the only way to salvage this patient, so they actually implanted the ECLS device there. So they continued during all this. They had high dose catecholamine usage to maintain circulation. Again, it was that team, the ECLS team with the surgeon, anesthetist, and perfusionist that got the cannulation and everything set up, and they were able to get it done. Again, it says the CardioHelp is a portable heart-lung assist system for transporting patients. Small device, quickly deployable, good for emergency situations. And it says immediately after they implanted this and placed the patient on the CardioHelp, the circulatory and respiratory situation was stabilized immediately. They were able to significantly reduce the dose of norepinephrine. They were able to adjust mechanical ventilation and improve the metabolic status of the patient. So it says when they did coronary angiography, I'm assuming this is on arrival of the hospital. One vessel disease, no need for intervention. EF was severely impaired. Patient stayed. It was intermittent AV blockage, is what intermittent third-degree block is what they are assuming caused this patient's arrest. So patient got an AICD. 4 days after the resuscitation, they did an ECLS weaning trial, got the patient off. 23 days later, the patient was discharged to rehab. 8 weeks after, was home, self-sufficient, mobile. So,
Cool.
it's pretty neat. I mean, it's one of those where
CardioHelp only be $6,000.
That was the second-hand one.
That's like on Amazon.com.
On some hospital selling it.
This is the console and motor is 110,000.
Yeah, that sounds.
That
right.
makes some
I mean,
sense.
Versus
I looked at one.
43,000 for the Centromac.
or do you partner with the hospital?
So maybe this was just a component of the setup.
Right.
or
So
something.
I mean, we looked at one that was
Yeah.
$80,000.
Or do you partner with the hospital, use their machine, take it to the field, and bring the patient
not
back?
portable.
Well, I say one of the hospitals that I had worked with, where I had trained, they had portable ECMO. They'd bring it down. Our hospital, we could initiate it, but we didn't have our own ECMO machine. We had our bypass, big giant heart-lung machine, but they would come down, they'd cannulate, and they would use a portable ECMO machine and transport that patient an hour and a half away to their facility where they could continue ECMO. They would fly or drive the team. Again, it would be a heart failure intensivist, usually a ECMO nurse and a perfusionist.
Yeah.
They bring them to our hospital, kind of like what this says, and initiate ECMO and transport. It was a small machine, but they knew by taking their machine to these hospitals, they got these patients back and they got to continue their care.
I mean, that's Germany though. Like they're very well known for having a huge pre-hospital physician system. It's not
Exactly.
uncommon to have.
Or France.
Or France.
Yeah.
They will have an anesthesiologist come out to somebody's house if they can't get him intubated. Like they have doctors on scene and
Right.
you know.
Very different.
It's,
There's a huge amount of resources to. I mean,
Right.
they're sending
Who's
how
unlikely
many
to survive.
physicians they send to the scene, right? And I think the question is, how do you really determine who's going to benefit from this and at what time period? You know, how quickly do you need to initiate this? I think there's so many questions that we don't have answers to yet, and I think it's definitely hard to implement something like this. But how well can you justify sending, 5, 6 additional physicians to a scene or to, do this? And granted, it would be amazing to save, one person's life.
Right.
But as that,
I mean, there's no reason why we can't do the procedure. I mean, a 23 French cannula and a 17 French cannula, and they're big, but there's no reason why Sellinger techniques. There's no reason why we can't do this.
right.
Yeah, I mean, especially if you if you have pre-hospital ultrasound, if you needed it too.
Yeah, it's all femoral. Right?
Yeah, it's all femoral access for the most part.
You don't need
No, that's what I'm saying. If you have it, you have the tool. I mean, the thing is, when you have
We get
multiple
to send the
physicians,
residents to it. We get to the residents.
you have multiple physicians on scene. I mean, you have when you have a surgeon, an ER doc, an anesthesiologist, all very proficient at placing lines.
Why do you need all those people? You just have one. All you need is one EMS fellow.
That's what I'm saying. In this study, they had these people that were all very proficient.
I mean, this is probably easier than intubating and running a code by yourself, right? I mean, it's one venous line and one arterial line. We do this all the time.
You can see one of our rotations will be the ECMO 2 weeks on ECMO.
I'm on pre-hospital ECMO.
That would be great.
All right. You're on endocrine. I'm on pre-hospital ECMO, buddy.
The new vehicle, MD ECMO. That would be it.
MDE.
So all we need is about $100,000.
If
All right.
there are any generous people listening
Any viewers?
to this Facebook Live right now,
Right.
willing to sponsor
$5 out of your paycheck every other week, and if we can get enough of you, right? So what's the bottom line here? That
It's a fancy, ambitious way to improve these patients in circulatory shock and cardiogenic shock. The thing is, it's again, and it specifically says a careful selection of patients, and you have to have a very structured system in place to address these patients. I mean, this was 78 minutes after the initial resuscitation. I think that's extremely long. I'm glad this patient had a good outcome, but like Josh had mentioned, when do you get this team in motion? Because especially depending on your location, it may take you 30, 45 minutes, an hour to get to where you are. So if you've already been resuscitating for 30 minutes, then you initiate the team. I guess the question is, and these are unanswered questions, when do you initiate this?
and this is a socialized healthcare environment, so with all the finances associated with that.
Exactly. So, I mean, it's a lot of resources to expend on something that we just don't have enough literature saying that it's going to benefit a lot of people.
Even at this institution, though, I mean, we have ECMO, and I can count on one hand the number of times that I've even, seen them consulted to evaluate a patient, in which case everyone comes down and talking about it.
Merlin's done it
You
3
don't do it?
times.
Yeah.
Yes,
I do
yeah,
it
so
like
you
once
just
a
did it?
shift.
Yeah, we just did. We've done a hint free.
We just did it this week.
And get an
It's
established
just
framework,
week.
I think it's so difficult.
Yeah, true.
Right.
And
And I think they do have the
heart.
heart. I've seen it.
They have I think they're hard
And
made
it's
threes now, but
The thing is, it's difficult to establish like go no go criteria. So
Exactly.
if you have
The problem is once you
set-
have them on it, these are $1 million patients at
Right.
that point. It costs up to $10,000 a day to maintain them on ECMO. Just $4,000.
right. But
for
Scott
the
Weingart always
ICU.
points out that VA ECMO in these people is a lot cheaper than the ECMO that we're used to in the hospital, right? Because a brief period of time and you get them off quick. So getting them off quick lowers the cost compared to keeping them on for a long period of time.
That's the thing. We need to have established protocols on when to take them off.
Right. And you got to have the right patient, and then
Yeah.
geography
Yeah.
always kills us because if it's an hour drive to put them on, what do you do now?
Yeah.
And that's
Yeah. I wonder what ethical issues it brings up. Like you said, putting
Exactly.
them on it, and then how long do you keep someone on ECMO for? Like, are they alive or
and
they're
having
not alive?
rules
and
to take
And-
them off, like
yeah,
all
and,
this
you,
stuff.
we
and you
talk-
do know you can make their blood work better like instantaneously with ECMO.
Yeah.
You
Right.
can make their ABG
Yeah.
better in most people, don't be not all. Like
And we talked about this last week. I mean, even TV shows have addressed this issue where you have people on ECMO and they're perfectly fine, but their heart is
The
not.
numbers look good. Yeah.
Yeah.
All right.
Do
Steve,
we have time for one more, or
One more.
should we go to board review?
Let's do one more.
Okay.
So one more.
There was actually an interesting comment made by Daniel Kempel. He referring to TEEs. Interestingly enough, it'd be nice to see. A lot of times, a lot of shops pre-hospital are now going to like king tubes or the supraglottic airways, and we're basically now kind of saying, well, sometimes intubation may not direct, laryngoscopy intubation may not be the right course, and we're using supraglottic airways. So now in that scenario, what's the role of a TEE? And you may not be able to get the TEE in, or you'd have to probably, your airway now would be, I guess, less, kind of secured, even with a supraglottic device, if you had to feed a TEE in. So that becomes a little bit.
Well, a couple of thoughts. One, I wouldn't recommend systems going to supraglottic airways. In the last few months, the Protect 3 trial, the Taipei study, and the France and Belgium study, which is yet to be published, but pretty overwhelming that paramedics should be intubating over supraglottic airways.
Sure.
But I mean, I think that otherwise it's like a reasonable point, because it does increase the risk of aspiration. Although it seems that all these people are doing pre-hospital ultrasounds or echoes or may not be doing the right thing, because it probably is taking more time off the chest. Okay, what's the other one, Navin? You gonna do one more?
Yeah, I guess we could do nebulized ketamine
Okay.
to avoid mechanical ventilation in a pediatric patient with severe asthma.
So we reviewed a nebulized ketamine paper or case report a couple of weeks ago, right? And I mean, what can't you nebulize now?
Right. It's kind of an interesting application of it, though. I guess let me just kind of.
Yeah, that's why I liked it. I liked that.
Yeah.
Yeah.
So this is from a group including El Hanoudi, I think is how you say it, out of Morocco. And they had a 26-month-old girl, 15 kilos, who came to the emergency room with respiratory distress, chest discomfort, wheezing, and basically lots of retractions. Preceding night, her mother said that she had a bad cough, really running nose, lots of wheezing. They tried some inhaled albuterol at home, but she continued to have labor breathing, and it just continued to progress through the day. At 8 months, she had a history of bronchiolitis and had to come into the PICU. And basically, some of the other family members also had severe asthma. So on this day, she came in very tachycardic, tachypnic, oxygen saturations were 90% on room air. She had a normal temperature. She got 3 doses of albuterol and some ipratropium, so Duoneb. And then she got a continuous 1 hour long duration nebulizer. And then they also tried giving her IV solumedrol, as well as they then gave her, later on in the course, some IV albuterol. Basically, despite everything they're doing, she's still, even on oxygen therapy and the nebulizers, her oxygen saturation
I don't know too much about IV albuterol.
92.
Yeah, I've never
Can you
heard
tell
of
me
that.
anything?
I don't know much about it. I've heard of it in there's other beta agonists that you can give.
I
Um,
I've heard of oral albuterol.
And maybe
I've
this
heard
is some of the limitations of
IV, I mean,
Morocco. Yeah.
but never.
So in Morocco, they give IV albuterol.
Maybe it's just limitations, or it's what they have, or I'm not sure.
Well, you have to think about the nebulizer. Although it's plentiful here, it's a big device. It's easy to crush. It's not very portable.
Right.
And then the availability of oxygen or even compressed air.
Yeah. I mean, interestingly, they don't ever mention epi, which I think a lot of people would go to early on. Later in the course, like I mentioned, she got the 2 IV bolus doses of albuterol, 15 mics per kilo, and then some magnesium as well. And basically, none of those seemed to help. They called down the anesthesia staff, but the blood gases were pretty poor, acidotic pH, not good ventilation, and then even with that, her oxygen stats were still stuck at 90 to 91%. They talked about using intravenous ketamine. They were worried that it would take too long to get started and get it going, and they were right on the verge of intubating this patient. And kind of as a last-ditch effort, they said, while we're setting up for intubation, why don't we try nebulized ketamine? And they administered 1 milligram per kilo into a nebulizer device, and basically for 20 minutes the child breathed the nebulizer, and over that 20 minutes had pretty significant clinical improvement. The respiratory rate went down, Tachycardia improved. They got a blood gas around that 20-minute mark. Her pH improved. Her oxygen numbers went up. Her ventilation improved. And her SATs also went up to 98%. They maintained her then on more albuterol, continuous albuterol for 2 more hours, was admitted to the hospital, but then went home uneventfully 2 days later. So basically,
Did she have bronchiolitis, or what was her underlying?
They said she had a cough and a runny nose. They didn't identify
maybe
a
it was
true
bronchiolitis?
source. She did have
So-
a prior bronchiolitis admission.
So Matt Harris, how about a study on nebulized ketamine for kids with bronchiolitis? Because we know the bottom line
I
with
think Matt stopped watching, and I don't see him active right now. So
I'm going to talk to Matt if you stop watching. Because I know that nothing pretty much helps bronchiolitis, right, except time. And maybe a little albuterol, maybe in certain patients. How about that? In a few patients, some albuterol helps bronchiolitis, otherwise it doesn't. But maybe ketamine for bronchiolitis, nothing else works. What do you guys think?
Why not?
I think is it gonna
there was
hurt?
the recent review. I think it was
Is it going to hurt?
DIMRAP that hypertonic saline doesn't. So literally, we're left with nothing.
Right.
But saline. And
Right.
that doesn't even help.
I think we've proven.
And a small percentage of kids will get better with albuterol, albeit small.
Right.
I think
So,
we've proven it's a safe drug.
so what was their bottom line?
So the bottom line is this is a novel route. There's been other case reports of using ketamine nebulized, but those are people who they would have otherwise used it IV. This is a person they were using nebulized ketamine basically to get the drug right to where the problem source was in the lungs.
And it's a
the question was
bronchodilator,
kind of
that's
like-
why it works.
That was the speculation. So they had to speculate. We're not exactly sure. They're thinking maybe it's the topical effect of the ketamine that can actually attenuate that local inflammation right there in the lungs. Maybe there's a component of just relaxing the child without compromising the airway. So other anxiolytic drugs we might be able to give would also decrease the respiratory status, and maybe that would worsen the outcome. And then there was one more mechanism that was, just to reduce the work of breathing, and then therefore kind of reduce the oxygen consumption.
Well, if that's the argument, then why wouldn't nebulized ketamine work for asthma?
That's a good question. Yeah.
So nebulized ketamine for asthma, for bronchiolitis.
I mean, I use it for IV, for asthma on occasion.
I think
Right, but not that
they
much.
mentioned that there
Same
wasn't any
doses,
really
yeah.
published
Yeah, it's
research
just-
on nebulized ketamine for these kind of indications.
Another indication for ketamine.
As far as nebulized ketamine, I only know of these 2 case reports.
Yeah.
That's it. I don't know of any.
So maybe this is the undiscovered thing for ketamine.
Yeah.
Next we'll be giving it for COPD, although COPD may not work.
I gave it once for COPD, more so just to kind of relax him a little bit because he was just terrified. Anxiety was really bad. And
So why don't you just give a touch of Ativan or something?
his family said he doesn't do well with benzos. I guess he'd had Ativan in the past and just had a terrible experience. So I was like, well, I'd like to calm him down, make him a little less anxious. So I just gave him a sub-dissociative dose of ketamine, and he was great. He just he tolerated BiPAP. He felt like $1 million.
So maybe it was an
about 20 minutes
anxiolytic
later.
effect. I mean that's probably what helps morphine in acute decompensated heart failure. People say, "Oh, I gave morphine, and I used to give morphine all the time for acute decompensated heart failure. It worked on everybody, so you should keep giving it." But I always say, "But you give morphine for many disorders, and people feel better, right? It doesn't mean that it's really helped anybody, you know." And in fact, that was Jerry Hopkins' study, where although it was a small subgroup analysis, I still remember the study. It was from 1979. It made people worse. You know, people got morphine in the CHF. And the 4 subgroups got worse when they got morphine, and the other groups did better. So, yeah, I don't know.
I mean, maybe this is something we should be adding to our arsenal. If you hit that asthma pathway and you're already on the path to intubation, I don't know. I hadn't previously considered doing this, and I think now
Maybe
why
a bad
not?
asthmatic.
As I'm
Done.
setting up,
Yeah, as you're
as they're
setting up, you
already
might as well.
going down that, getting ready for that.
I
It's worth a
did.
shot.
But we,
Yeah, you have the ketamine there to do for
Delayed
intubation.
sequence.
Right,
You give
exactly.
it, just put some on.
yeah,
and,
not to delayed sequence DSI. But I mean, but we'll give a bunch of CPAP for asthma, even though there's not overwhelming good science on CPAP for asthma. So you have somebody on CPAP, and then you connect a neb to it, and then you nebulize through their CPAP ketamine.
Yeah.
Right?
I think it would be interesting also to look at like nebulized ketamine or IV ketamine versus just Ativan or a little bit of Versed in these people. So if it's just an anxiolysis thing, then benzos may have the same effect as well.
But
Right.
You
Or
can
maybe
imagine
it's placebo effect
Right.
too. I
Mhm.
mean, that's the only other. I mean, it's only case report. So
Yeah.
I mean, some people have to get saline, but then you could argue maybe the saline was having a benefit for bronchiolitis,
Right.
which we doesn't anyway.
Insensible water
I mean, you
loss.
can imagine kind of just the clinician anxiety of giving this really sick kid who you're about to intubate, giving them some sedatives.
And I feel better.
Right?
Yeah.
They may feel
I don't
better.
know.
Worst
So
case
I'd
scenario.
I'd probably
you're
give
in
myself
bed.
the sedatives.
We dissociate
Yeah.
these kids, then they have bad dreams, but they don't get intubated.
Yeah.
On the other hand, these kids can tolerate pulse oxygen very low. We don't rush to intubate them anyway, right? All right, that was good. So we're gonna move all the other articles to. So we're not doing Journal Club next week. We're just doing operations because it's the 5th Wednesday of January. I'll take these articles. I'll push them to 2 weeks, and I'll submit a bunch more. A couple people have submitted articles to me. I always try and include them as long as they're good, but some just aren't on PubMed yet. So as long as they're PubMed or available on Google Scholar or something, I generally include them. Oh, thanks. This week we were at Jacobi, Montefiore, and Einstein residency. A huge residency. They're very nice to us, talking about EMS fellowship. So thank you for that. And any other announcements?
I think that's it for now.
No. Okay. All right. Sounds good. We will see you in 2 weeks. Thanks a lot.
Okay.